So welcome everybody. My name is Kelly Kay and I'm the Executive Director of Provincial Geriatrics Leadership Ontario. And PGLO is funded by the Ministry of Health to help coordinate clinical geriatric services across the province. This is a demonstration of the data entry that's required for the specialized and focused geriatric services asset mapping initiative. And I'm going to give you a little bit of background about PGLO in just a very quick slide, do a bit of an overview of the project for those who haven't seen it before, tell you about a few of the products that have resulted out of this project that you can explore in more detail, and then raise some ideas about how we can start to use the data that we're collecting. And then I'll go into a demonstration. I've got time for, we'll have plenty of time for questions afterwards. And I've got a few frequently asked questions already prepared in case you haven't thought of some of the questions. We can also ask questions as we go through. Stop me if you need anything clarified further. This is a contributor-led project, so there's no magic upper tier boss that is directing how this project unfolds. Really, it's contributor feedback that is shaping the data that gets collected and how the data entry looks. So a little bit about PGLO in case you haven't met us before. We coordinate the clinical infrastructure, as I mentioned, for geriatrics, and that includes about 1,600 providers who have additional preparation to provide care to an older adult population living with complexity. And there's about 200 programs and services currently reporting. We're focused on the population that has complex health conditions, and we're funded by the Ministry of Health. We're not an advocacy entity. We're an entity that is intended to support capacity planning, as well as the identification of clinical models that are effective and the distillation and preparation of standards of practice. So we synthesize perspectives across clinical geriatric services, and that includes care of the elderly, focused practice, geriatric medicine, geriatric psychiatry, seniors mental health, and interprofessional geriatric teams. And some of you may be familiar with this and some not. And just on the right-hand side, this is a bit of the way we describe where geriatric specialized geriatric services fit within the continuum of care. And certainly we know that there are focused geriatric services operating in different places within the system as well. So this isn't an exclusive club. What we want to try to understand is how are people going about caring for a population living with complexity. And some of that may include primary care-based models as Ontario health teams are unfolding. So this, just as a quick overview, this was a major deliverable requested by the Ministry of Health when they funded PGLO back in 2018. And what this is about is a contributor-led portal of data that has information that's accessible for planning. So our deal with the ministry was that if we're going to lead this work on behalf of our colleagues in the clinical services, all of the information needed to be available to them. And so that's why you can search and look at information. And that's why the report that we produce is so comprehensive, because it provides you as managers with planning information that you can use in your day-to-day work. And so this is really a comprehensive current state inventory that can be used for planning and can also showcase effective clinical models of geriatric care. Sometimes we get into the habit of reinventing the wheel when in fact there's been effective models in operation for some time, and there is no other place where this information is displayed. So some of the things in our first year of data collection, we collected 17-18 data, and that resulted in 3 reports. Two on the left-hand side were focused around physician human resources, and the one on the far left that's titled Specialized Geriatric Services in Ontario, that actually turned into a publication that was published in 2018 and led to a subsequent publication about geriatric physician specialist human resources. The center document was drawn from ICES data, and it gives additional information about dementia, frailty, and the utilization of physician specialist services, including geriatric psychiatry and geriatric medicine, as well as, I don't think that one includes care of the elderly. There may have been a little bit of data around care of the elderly, but the first report does include care of the elderly. The last report on the right-hand side has now been taken down because that only included the 17-18 data, and it has been replaced with this report that is now a 3-year look back. So now that we have 3 years of data, we're going to continue on with a 3-year look back. So there'll be some trending information available for you to look at, and we can be monitoring what is appearing and disappearing on the scene from a geriatric services perspective. This new report offers you, if you've seen the previous one, you'll find in this report there's a little bit more contextual information, as well as some summary and detailed tables and maps. And there are some regional comparisons. So this may be helpful to you as you're thinking about the services that you may need in your local community or within your organization, and how you stack up against organizations that are similar to you and may be serving a similar population size. So if you haven't seen it yet, do take a look for it, and I'll show you in a moment in the demo where all of this is located. This is just a sampling of some of the data visualization now available for you. I show you this one because there is a little bit of a misconception that when we're talking about the older adult living with complexity, we're only talking about long-term care. In fact, when we look at what you submit in terms of data, we find that we're actually working quite a bit within the community as well as other sectors. So this kind of information may be helpful to you as you're thinking about service planning and trying to show that, in fact, yes, indeed, there is a presence in the community or in other locations. This is another bit of a snapshot that appears in the new report that helps to sum up what the volume of activity is, so the utilization information, if you will, as well as the number of programs. Geriatric services tends to suffer from a lack of profile, so having this kind of information could be helpful so that the presence of geriatric services in the province is more easily recognized. And then this kind of information helps to provide a bit of comparative analysis across regions and also across years. And so this kind of 3-year look back may be helpful to you as you think about your own region and what's available. Now, there are still data gaps, and that's sort of my pitch to you, is to assist with the filling of data gaps. We know, for example, in Central Region that those 6 geriatric emergency management nurses that were there in 2017 didn't vanish in 2019-20, they just weren't reported. So, as we improve data quality together, we will have more reliable information we can use for planning. But this starts to paint a picture of where there's density of services and where there may be missing or low density, but in fact, not keeping up pace with population growth. So that's just a bit of show and tell for you, but a couple of the uses of data, and of course I'm a keener, and so you'll find that I can find lots of ways to use the data, but you may find it helpful for informing planning and decision making about interprofessional geriatric services. This data is not available anywhere else. If you were to do, an applied health research question request through ICES or other sources, they cannot mine the interprofessional team data. So by providing this data, we are filling an important data gap, because geriatric care often is carried out with interprofessional teams. And in fact, that's quite critical to the work of geriatrics, but there's no other repository that will tell the story of what actually that means and looks like and how many people are involved. This data can be used to identify core clinical models of specialized and focused services. So when we're working with our Ontario Health Team colleagues, and they're trying to think about what kind of service design may be helpful for the population that they're focusing on, and we know that more than 50% are focusing on older adults living with complexity, then knowing that there's an array of models that could be brought to bear on some of those questions could be very helpful. And this also helps to raise questions about gaps in anticipated demand. And we also have complementary work estimating the prevalence of frailty by census division on our website. So that could be a way to look at conducting gap analysis, either locally within your organization or in your community. So those are a few uses that come to mind when I look at the data picture. So I'm going to move to the demonstration now. The way I'll go through the demonstration is I'll take you to our web page so that I can just orientate you. I will show you some of the paper resources or print or downloadable resources you might want to have at your side as you're going through actually completing data entry. This just might make your life a little bit easier, including some of the narrative requests. And then I'll jump into the portal and walk you through how to do the actual data entry. We'll just come back and check in around questions and then we should be done for the morning. So we may not take the full hour. I'm going to flip over now to the web page, and hopefully you're seeing a website. Julie, would you just confirm if you're seeing the website? Can I get a confirmation that you see the website?
I can see it.
Perfect, thank you. Okay, so this is the front page of the PGLO website. You'll see the address up in the corner in case you don't know it. And right here on the right-hand side is the button that you're going to care most about when you're trying to do this work. So Specialized and Geriatric Services Asset Mapping Initiative. You can simply click the button. And if you want more information about the genesis of this project, you can read all about it. Some of the major reports, the current state report that I showed you is the top report. And you can just simply click on that and it takes you to a page where you can download that report. And here it is here. So you can go through all 145 pages of it. You may actually just want to jump right to the section that's most pertinent to you in your region. Or you can read the whole thing. I'd love to have your feedback. There are the other reports, the physician related reports are here. And then to get easily to where you have the resources to put in your data, you're going to look for this link right here. That's the Asset Mapping Data Entry Portal. I mentioned that there were there was a publication that arose from for one of the earlier reports, and I've created a link for you here so you can follow that if you're doing physician human resource planning. But we're going to focus in today on the Asset Mapping Data Entry Portal page. This takes you to a page that has a few resources on it. First is a portal link, and we'll go there in a minute, but there's paper copies of the documents that are going to be helpful to you, including all of the service types and definitions. And we'll talk about that in a moment. But what that is a listing of the definitions of the different categories of services. I'll show you again in the portal where you can find that too. But one thing I would recommend here is clicking here. You see this one says download a copy of current requested data elements. And this might be handy to have at your side. This page, it's a Word document that explains what each of the data elements are. So if you're not familiar with this and you're not really sure, what do you mean by name of service? Take a look at this and have this on your side. One of the things that some groups do, especially regional groups, they make their own little templates and they send them around to their colleagues, and then one person enters the data for everybody. So if you're planning to do that, you could just grab this sheet. It's in Word so that you can modify it, and you can just grab it and take it and turn it into your own template. So that'll be a bit of a time saver for you if that's something that you're thinking about doing. So keep that at your side as you enter to the portal. If you click this link here, then you'll be taken to the data entry portal. Remember, we are not looking for any patient level data, so there's no PHIPAA concern here. And then if you have never registered before, you would click here to register as a new user. This prompts a request for approval. It is not done automatically. We vet every user, and so it is a human in the background. It's either me or my colleague Adam Morrison who actually review all the requests. We try to turn that around very quickly, but if you don't get a response right away, and you're doing it in the middle of the night, it's because we're asleep. So just know that it's not an automated process. And that's just to protect the integrity of the portal, because it's a shared data entry site. So this is it. It's not very complex. You enter in here and you have two choices. One is data entry and one is an asset map. I'm going to go to the asset map first, just so you can see what you can do. Here you can look for comparator data easily. I mean, you have the big printed report, but if you just want to get a picture of a quick picture of some comparative information, for example, maybe I'm interested in all the geriatric psychiatry outreach teams in the province. I can select the fiscal year and the particular asset that I want to look at, and then I can click show selected assets, and you can see that they appear on the page, and I can just make that a bit bigger and move it around. When I click on a button, I can get specific information about that site. And that if I'm interested in maybe reaching out to colleagues, or I want to know where they're located, or I'm doing regional planning or something to that effect, you can then use this kind of thing and take screenshots and put them in presentations, etc., to help you with connecting with colleagues in similar areas, or making the case for the need for new services in a particular community. And there's some density overlays that you can use. You can show community county boundaries. I'm just adjusting the filters to at the bottom here. You can show where the population over 85 is located if you're particularly interested in that. So that's just one way that you can make use of the data that's input. And now I'm going to go to the data entry page. So this is the page where you will put in your data. It's not a very complex page. I'll show you what it looks like in a moment. Your first task is going to be to select the facility name, and the facility names are attached to you as a user when you register. So for me, I've got every single facility that has geriatric services attached to my name. I'm going to use test facility just so that I can find this data later and erase it. And I'll pick the fiscal year. Now you will need to do a different form for each fiscal year. So, and I'm asking you specifically for the 2020, 21, and 2021-22 fiscal years. If you are going in to make a correction to a prior fiscal year, remembering that we will also be publishing 2019-20 data because it is a 3-year look back, then you would change to the fiscal year that you're trying to work on. So I'm going to work on the 2020-2021 fiscal year, and I'm going to pick a service type. Now, if you forgot what all those service types are, this handy question mark will load up all the definitions. And you can select the definition that best suits your program. I just want to raise the caution for you. If you don't see a service type that fits your program, I urge you not to try to force fit. What you can do is you can pick other. And you can see if I select other, it allows me to enter a new service type. Now, this is not the name of your program. Maybe you call your program a GAIN team or a GOAT team or a GMOT team. It's not the name of your program, but it's a new type of a service. So think of a broad category here that would best reflect your service, and then define it, because you as the contributor know this best, and there may be others like you who are offering this kind of service that's not well described already. So if you don't see yourself on the list, don't force fit. In this case, I do see myself on the list. I'm going to pick the Geriatric Psychiatry Outpatient Clinic, and I'm just going to load the form. I'll show you the totality of the form. It has this general section where I get to enter the actual operating name of my geriatric psychiatry outpatient clinic. Maybe I've got a fancy name for it, and I put the name in here. And then we're asking for program statistics, full-time equivalents, a little bit of narrative information, and whether or not you're serving only people over 65, and your referral sources. So it's not a very long form. It's intentionally simple. I previously been a clinical manager, so I also am sensitive to not making an overly cumbersome form. So if the name of my service is the Mount Hope geriatric or psychiatry, I'll call it the Mount Hope Mental Health Service, then I would type it in there. So this is whatever you call your service. And then Just take note of the directions here. Just complete the applicable fields. This form is for both bedded and non-bedded services. So you're only going to fill in what's relevant here. Because it's an outpatient clinic, I'm going to put the visits in there. Maybe we do 500 visits or 500 visits a year. These columns do not total into the visits, so you will need to break it down. So maybe I do 100 in person and 45 telephone, and the rest are video visits or something like that. So I'll enter that data in there. I'll make it a little easier in my math here. And 300. So you want to make sure that you account for your visits. Some of you may have a number of appointments that you make available each year, a set number. In some programs, they know that they make 1,500 appointments available each year. And some services take whatever comes, like geriatric emergency management nurses do not make appointments available. They're taking whoever comes into the emergency department. So if your service has a schedule where you know the number of appointments you make available each year, you can do that. Why that's important is because we can often show that we're exceeding demand if we know what we intended to make available, but then we actually report who we served. Many times we see that we are serving more than the number of appointments we actually made available. It's just another measure of demand. So we want to be able to reflect demand. Enter the number of unique patients served. Many times geriatric programs are telling me that they don't collect the caregivers served. And this is something I'd ask you to reflect on, because we do want to show our colleagues in the behavioral supports world do a very good job identifying caregivers served. And I can't think of a single geriatric care plan that doesn't think about the needs of the caregivers. So we are actually serving caregivers. We're just not capturing that data. So feel free to estimate if you can do so in a reliable way, or if you are collecting that data, that's fabulous. If it's a bedded service, you're going to fill in the beds in service, you'll fill in the occupancy rate, and that actually helps us to do some additional capacity planning calculations. So give us as much as you've got, but don't stress over it if it's not something you normally collect. We're not asking you to go back and do primary data collection. You do need to fill in your office location and your postal code. And if possible, we are asking you to adjust and put the tab, the pin in the location of your actual service, so that we get an accurate address location for the mapping, and that's got us right in the middle of a park. But you just drag them, and this is the only fiddly bit, is to drag it down to the actual location, and you can get quite specific to the street that your service is located on. So here we're located over on this street at the end. So you want to be as specific as possible, because we can use the mapping information then to help with planning in terms of location of services. If you're operating in more than one location, add the additional locations. Sometimes what we notice is that people are running a service that's home base is in one place, and but you're operating satellites elsewhere. Okay, just and then the health region, I'll get to that chat question in a moment. The health region, you pick your health region, have separated north for those who are working in the north, and then the counties served. So then just identify which counties you're serving. Again, if you're serving all, or if that's not really a relevant question for you, you can leave it blank. So just fill in what you can. We're trying to get as much as we can. Now, there is place here to upload attachments, and this is especially important if you've created a category. I really urge you to upload a description of what that service is. Certainly want to try to capture novel programming, and we're starting to do some qualitative analysis of the model descriptions that you're providing, so that we can see what the features of geriatric services actually are. This is also where you could upload a patient's story. So anywhere where there's a place here's the place where you can upload a program story. If you can upload it in either location, but that's just to let you know you can put attachments in that give you a bit more information, that can give a bit more information about your program or service. Here's where you can record all your full-time equivalents. I would urge you to try to attach, if you do have physicians working with you and supporting your service. I know that full-time equivalents don't always translate well for physicians, but if you are able to attribute any physician time to your service, then that would be helpful, because we don't have terrific data about current up-to-date data about physician support. For everyone else, please put in your FTEs. And if you don't see some of the categories of workers that work in your program listed here, then use the other category and then specify who they are and how much they're contributing. Now, you might be thinking to yourself, well, in the years that you're asking for, everybody was redeployed. I think what I'd like to point out is we do have this field about the FTEs redeployed. What I would urge you to do is fill in what your program is supposed to be offering, and then how many of those FTEs were redeployed during the fiscal year. We do want to track what is now missing from geriatric services in order to keep a line of sight on what is returning, because that may become problematic as time goes on. Here's the location to upload the program stories. And if you need that success story template, the template is handy right here. And then there's a final place for any other comments that you just want to jot down or make note of. And here's also the place where if you're having any trouble with your record, or you have corrected another record, or maybe you saw the wrong organization name in 2017 and you want to change that, but you can't change the organization name and you've created a new record, feel free to put any comments that will tell me that there's some duplication, or there's been an error, or there's some feature that I just need to watch for as we're doing the analysis. Here's where you just indicate the percentage of your patient population that is age 65 and older. Some of you may be serving a mixed population. And then finally, who's referring, or what are the sites of referral. For those of you who participated in this last year, you might have seen that this field was blank. And the way we managed to get these different categories is because of what people wrote in this field here of specifying. So if you're not seeing a referral category that's relevant to you, write it in this field here, specify, and then that'll allow us to update in future years. So again, contributor led, your feedback and your reality check about the data sources is going to tell us the most about how to collect information and tell the story about these programs. Then you click save and you're done. And then you would need to do a second form for a different fiscal year. You can just go back up here to change the fiscal year to 2022 and then load the form. And if you're running more than one program, then you could change the actual service type as well. So you can just stay right in here and move around. So I'll stop right there for a moment and just I'll check in on any questions on this part here, and then we'll go back to some frequently asked questions. So I noticed that there was a comment in the chat. Somebody just wants the questions on the screen to be able to, I'm not sure, Jennifer, what questions on the screen were you referring to?
Oh, hi, it's all of them, so that way I can show, because I'm not too sure who's running the program at our site, so I can just show them what the questions are being asked, and then they can determine who would be the best to respond.
Do you mean the data elements?
Yes.
Okay, very good. Thank you. Just that helps me understand what you're looking for.
Okay.
Absolutely. I can follow up with the link. I'll just pop the link in the chat for you now too, so you've got it.
Okay.
And then you've got that handy where you can take yourself to the place to locate your that data sheet. So I'll just put it right in the chat for you. The question in the chat is, if you are working in the form, does it automatically save for future input, or do you have to add all the data in one go? You should save before you leave. So if you are working on that form and you have to go away and do something, do save and then come back. If, say, for example, you're entering everything, but you just can't remember the FTEs of your pharmacist, save and then come back and enter what the missing piece later on. someone's asking about specialized assisted living for high-risk seniors or specialized transitional assisted living. Yeah, there isn't a category for that, so that would be helpful. That is sort of a new and emerging kinds of categories, and that's a really good example of when you would use the other category and then give us that new name, that new category, and offer us a definition. What does that mean? What's that involve? And give us some sort of description. And as those new categories get created, we're working to try to reduce the number of overall categories, make it a little bit simple. I think the most challenging thing people have identified for me is that they have trouble figuring out what category they fit in. So we want to try to make that a little bit simpler. So we will be working to try to group the existing 30 categories into more general, broad categories. Any feedback on that is also welcome. Shauna, you were saying is the save button at the bottom of the form, and I'll just go back and show you where it is, just so you're not lost. When you're looking for it here, we'll just go back and take a look. So the save button, yes, indeed, is right down here at the bottom of the form, bottom right-hand corner. Okay, if there's no other questions there, I'm just going to go back to some other frequently asked questions that sometimes crop up as people are working on this.
Kelly, it's Julia.
Oh, go ahead, Julia.
I'm just wondering about the data element around redeployed.
Yes.
What if you had workers who were redeployed for, let's say, 6 to 8 weeks, so only a small period of time within the whole fiscal year?
Mm-hmm. So you could calculate that using the time frame for like the hours. So we know that each FTE is 1,950 hours. If you think it is substantial to the functioning of your program, or if, because we are reporting visit volume, if it's presenting itself as a problem in terms of a major drop in volume, then you may want to have some explanatory information that shows that redeployment. And you could calculate that by figuring out the proportion of the 1,950 hours that were actually redeployed and just translating that back into an FTE. You know what, I'll put that in I'll make some frequently asked questions to show people how to do that. And then that way I'll put that on that portal, that link to the portal page, so that you can find out how to do that. Will that help?
That sounds excellent. And I think it's impact, but it's also contribution. So it's both out, so I think that would be great. The next question, I'm just wondering if you just make some comments. You've said two terms. You've said specialized and you said focused.
Yes. Thank you. And you can see it here. Initially, when we started out, we were interested in mapping the services that were considered to be specialized geriatric services. And that language had been historically associated with geriatric medicine. From a PGLO perspective, we immediately broadened that language back in 2017 to be inclusive of seniors' mental health as well as care of the elderly. But we know that there's a lot of activity happening in primary care now, and especially as the Ontario health teams get rolling. And so we've added the language of focused geriatric services. And the distinction there is, this is not just bumping into the older person in the passing of everyday work. This is taking time out to prepare special programming that's intended to serve their unique needs. So this would not be counting a visit just because an older person has shown up in primary care for a blood pressure check. This could be something about a memory clinic operating in primary care, or a special program that is intended to serve older people living with frailty and includes a level of skill and concentration focused around their particular needs. I'm being a little bit vague in my response because I want to leave the door open to what the emerging innovation. And I want to steer us away from creating an exclusive club here. I want to recognize that there is a certain degree of specialization required in many of the services, but there are also other people who are making a contribution to the care of people living with complexity. And we want to know about all of it. For those who work in specialty services, knowing that there's this growing cohort of groups that are offering what they're calling focused geriatric services gives you a clue of who you might want to connect with to support. And likewise for them, knowing about the availability of specialized services, they could be reaching out for clinical expertise. So thanks for the question, Julia. I think we want to steer away from being entirely exclusive, but we also want to make sure that what we're talking about is intentional work and people who are taking the time to acquire additional preparation and creating programming that is focused around the needs of older people living with complexity. Just going to go just to the frequently asked questions for a moment. So I've pretty much gone through the first one around if my program doesn't fit. So don't force fit, use the other category, create a new category. I mean, do take a look, see if you can, if it does fit within an existing category. But if it doesn't, do use other and define a new category, and we'll thematically try to organize those into new groupings. And if you are adding a service type, you think that you've got something novel, you don't see it reflected in the existing list, then do take the time in particular to upload a description of the new service, because this is how we can capture these innovations. If you've made a mistake or you need to change a record, first of all, maybe make sure that you have the copy of the report from the last year, the last 3 years beside you, so you can see what your program or service was called. And then you can call it up by entering in the fiscal year, service type, program, and program name, and reloading that form, and you'll be able to make the correction. So maybe you see something in the previous report from 2019 that's wrong. You'll have to use the exact name that was typed in the way that it was typed in order to get back into that record to make the change. Even if it was created by somebody different previously, you can go in and make the change, but you'll just need to know exactly what the program was called. And then, or very least, I've had some people who have made a mistake and they can't quite figure out how to change something, so they just put error in the comments, and it's an alert for me. I'm the one who personally goes through all of the data and does the analysis, and I pull out all the duplicates and errors. And in the last go around, there was over 1,000. So if I see error in the comments, it just helps me know that that was something I got to take out. We talked a little bit about should I bother, and I liked what Julia said. She said it's both impact and contribution. So impact on specialized geriatric services, but also contribution to the pandemic. So I think that's an important story to tell, and it's a good clue of what we might want to put in next year's report as we talk about redeployment. So yes, you should bother. Please don't think it's a waste of time. It's all part of the story of what's going on for geriatric services. And lastly, the last sort of frequently asked question that I've heard so far is, if I know of a program and I don't see it in the last report, can I share the request? And I would urge you to do so. Please, let's get as complete a picture as possible. Urge your colleagues to participate so we've got better and better data to use, and feel free to spread the word. And that's really all I had, just a sense of what the timeframes are. Pardon me, just go back to that. A sense of the time frame. So we've launched the form and the request for data. We're leaving it open to give you lots of time. We'll pull the data off after July the 15th. So if you can get your updates in by July the 15th, then our next report will be as complete as possible. You may see some reinforcing communication either from us or from the ministry or from Ontario Health, but you may get pestered a little bit in the months of May and June. And then after July, we'll be pulling off the report for the data we've received and starting to prepare a report. We do have a working group that meets annually, and some of you are on the call today, and they just look at the definitions, the data elements, any cleanup that we want to do to some of the reporting categories. I've already heard that somebody would like a new category, a new field for home visits reflected, because that's not currently listed there. So those kinds of corrections, and feel free to put any of those insights into the comments too. I will mine the comments for any good advice, or send me an email at any time if you've got thoughts. But just to caution, if you send me an email and you've got good ideas, you might get invited to the working group. The working group only meets once a year. It's not a high burden working group, and that's their task. And then during the summer, I'll be doing the analysis and the writing, and then we will send out a report for validation. So you will get a copy as a contributor, you'll get an advanced copy of the report that we've prepared. That gives you a chance to see if there's any errors. And then we'll be modifying the data entry portal for the next year. And by December, after you've had a chance for feedback, then we'll have a final report that stands and will be on the website for everybody's use. The field validation report you can start using as of September or so, but usually that generates a flurry of activity as people realize that something was missing. So that's kind of the process that we'll be following this year. And that's really it. This is my contact information. I'm your go-to person on this. So if you are having any trouble at any time, it's not a nuisance, just send a message. If we have to do a quick Zoom call and I walk you through, I'll do that. We want to do as good a job for all of us by having as complete a picture as possible. So that's really it. I'll just double check that there's no other questions. Any other questions, comments? Okay, thank you. Good luck. I'm here to help. If you need anything else, get in touch. This video will be posted on the website for colleagues who are not here today. Thank you, everybody, for participating.